All right, I think we'll get started. Thanks for joining us this evening. I'm Mike Gibson, and welcome to the PERT Town Hall. Tonight we're going to be talking about data gaps in acute PE and VTE management in 2020. We're going to focus a lot on COVID as one of the disease states obviously associated with thrombosis. We ask that you mute your microphones. We're going to make this interactive. We want you to participate, and there are going to be three ways you can ask your questions. You can click at the bottom where it says Q&A and type your question in there, or you can click where it says chat and you can type a question there. Or finally, at the end, when we go around and see if there are questions, you can raise your hand and we'll unmute your line so that you can ask a question. Again, we want to make this interactive and enjoyable for everybody. Well, I'm joined tonight by a group of great panelists, Kenneth Rosenfield, Eric Secemsky, Robert Lookstein, and Rosovsky. And they're just superstars in the field. A couple of other housekeeping notes. I want to make sure everyone signs up for the PERT annual meeting. This is the 6th annual meeting. Is that right, Kenny? You're on mute, Ken.
It is indeed, and we're really looking forward to it. It's next week, and Rob Lookstein is on the call tonight, and Vic Tapson are the two course directors, and we have an amazing lineup, and they've really it's going to be a fantastic course. And in fact, there's some special items that are going to be, we won't tell you about them, but some special items that are going to be displayed during the course on Saturday afternoon that I just heard about today. So I hope everybody participates. It's the only course or conference that is completely dedicated to pulmonary embolism and VTE, and people will learn a lot from it.
Can we have the slide that shows the link where you go to sign up? It's pertconsortium.org. One more, there it is, pertconsortium.org. Go there and register. And again, the meeting is in about a week. Well, why don't we get started? I'm going to start with you, Rachel. What do we know about COVID and VTE? I mean, what are we learning about the pathophysiology? I mean, people have said this is an endotheliitis, or there's complement activation, or both. All this in addition to the traditional risk factors. What's the basic science teaching us about the relationship between COVID and big vessel thrombosis, both in the arterial side and venous side, and microthrombosis?
Well, I think that's a great question, and we are learning a lot scientifically about this. And the first thing is we started to get some autopsy studies, which show some fibrinous-like microthrombi in the interalveolar septum of a lot of those patients. And we've also seen diffuse alveolar hemorrhage and damage and perivascular T-cell infiltration. And I think there definitely is a connection between this COVID coagulopathy, and we're learning more and more about it. And I think it's an interaction between both inflammation and coagulation. And so what happens is when you get the severe acute respiratory syndrome of COVID, it infects the cells that express a surface receptor called ACE2. And what happens is when it does that, it starts to replicate and releases the virus. And then that goes on to cause the host cell to undergo something called priotosis, which is a pro-inflammatory apoptosis. And it releases these damaging associated molecular patterns. It activates oxidative stress. It generates these pro-inflammatory cytokines and chemokine release from nearby epithelial cells. And then these proteins in turn attract inflammatory cells to the site of infection, and you get this feedback loop. On top of that, tissue factor, which is usually hidden in the subendothelium, during inflammation, it gets upregulated. And that leads to activation of both what's called the intrinsic and extrinsic coagulation pathways, which then make fibrin or thrombin. And as you said, there's a lot of studies coming out looking at complement activation. That's another big part of it. And then thrombin binds to some receptors to promote the formation of fibrin. On top of that, we think that the natural anticoagulants and natural fibrinolytics are downregulated in this virus. And then if you look at the small pulmonary vessels, you can see fibrin and platelets and these neutrophils that get trapped in something called neutrophil extracellular traps as they pass through the lung. Then you've got this ongoing inflammation, which causes the feedback loop. You've got procoagulant stimuli from lung hypoxia. And so it's this whole interaction of all these things going on, which is just upregulating all of this inflammatory response, which we think is responsible for all this. Now, whether the same mechanisms are causing the macrothrombi to the immunothrombi or microthrombi, it's not known. And on top of that, these people are sick, they're lying in bed, they're immobile. Inflammation, as you know, contributes to hypercoagulable states. So I think it's this whole combination of what's happening. And like I said, we're learning more and more about it. But when we think about all those different pathways that I just mentioned, you can then think about, well, what kind of targeting agents could we do to try and stop that pathway and that feedback loop?
So you talked a lot about the lung, but to be clear, Rachel, we also think that a lot of this involves the endothelium, correct?
Exactly. That's exactly right. So the endotheliolitis, that's the whole inflammation where it's releasing all these chemokines and cytokines and just upregulating the whole coagulation system. So there's a lot of literature about that too.
So talk to us about treatment. You recently put out some PERT guidelines.
This made all of us run late.
And, you know, there's different settings that you treat people in. I mean, there's someone who's in the outpatient setting. There's someone who's pretty stable in the inpatient setting on the ward. There's the ICU patient, and then there is the person who's been discharged. Now, I imagine all those are different, and the choice of drugs and the choice of doses may be different for all those scenarios. Walk us through some of your recommendations.
Yeah, so that's a really good question. And I think just taking a step back, when we first started to learn about this disease, very early on, there were some papers that came out about the D-dimer. An elevated D-dimer was associated with increased mortality. That's been shown time and time again. It's also been shown to increase risk of bleeding and thrombosis. So very early on, there was a study out of China where patients with severe COVID, about 20% of them got prophylactic anticoagulation. And when you looked at overall survival, it was exactly the same. But in the subset of patients who had a D-dimer greater than 6-fold upper limit of normal, there actually was a survival advantage of about 20%. So that led everyone to think, oh my gosh, elevated D-dimer, maybe we need to put people on even higher doses of anticoagulation. And the problem is we do not have randomized controlled trials right now that tell us whether or not anything above a prophylactic dose of anticoagulation is going to decrease the risk of thrombosis or increase survival. We just don't have that data. So right now, oh, go ahead.
It's tragic that we don't have that data, right? I mean,
yeah.
It's a fundamental question.
Yeah. Well, fortunately, there are a number of studies going on, and I would guess that every panelist on this call has clinical trials at their own institution actually looking at this, and the NIH is actually funding very important studies. Those 3 scenarios that you just mentioned, outpatient, discharge, and inpatient. But at this point, the data that we do have, and I think what is being recommended by a number of different guidelines, if you just Google COVID-19 and VTE guidelines, about 15 will come up. And so there's lots of different guidelines. Jack put out guidelines, we put out guidelines, Chess put out guidelines, AC Forum put out guidelines, lots and lots of guidelines. And I think if you look at all of them, any patient that's hospitalized, I think across the board, recommendation is at least prophylactic anticoagulation. And that's based on what I just said, is that we know that there's this upregulation and these patients are at increased risk of clotting. The exact numbers of clotting are all over the place. If you look at the European data, the rates are as high as 60, 70%. You look at the US data, it's a little bit less. We looked at our own data, we found the rate to be around 4.5 all comers. So it definitely does vary. I think the question you asked about what do you do with the ICU patients? Because we know that those patients have a higher risk of clotting. We found that in our own data. That's been time and time again shown in various studies. And so people get concerned and they think, well, we need to give more. Maybe we need to give intermediate dose. Maybe we need to be full dose. Maybe we should use the D-dimer to do that. And again, early on, we didn't think that there was a lot of bleeding associated with this, but we are now seeing bleeding associated with it. So right now, recommendations, and in fact, the ASH guidelines just came out last week, where based on very weak data, because we don't have the randomized controlled trials, right now the recommendation is to keep everybody on prophylactic dose anticoagulation regardless of ward or ICU. However, really to take into each patient individual, right? Because if somebody has, you know, more than the average risk factors you might think about going up, we do go up, and obese patients will use intermediate dose. But beyond that, we are putting everybody on a clinical trial where if they have a D-dimer greater than 1,000, they get randomized to prophylactic anticoagulation versus full dose, so that we can answer that question. And again, if you look at clinicaltrials.gov, there's about 42 trials going on now with anticoagulation and COVID. And I'm hoping through all of these various trials that we can answer this question. So I think it's important to think about that, but also really to treat each patient individually. And then I think your question about discharge, we don't know the data about that, although out of the BI, a paper came out where the number of clots that were happening once patients got discharged was very, very low. There was also a presentation at International Society of Thrombosis Hematasis, was very low. So we, again, don't have the data that those people need to be put on blood thinner, but that is going to be one of the clinical trials that's coming out of the NIH.
So at 42 trials, we'll probably have 84 answers.
We might.
I wish we just, I wish we were more like the UK, where, you know, they got one trial, they get a definitive answer. But, you know, as Americans, we love to be independent. It's probably a good stopping point to now ask the audience what they're doing. Perhaps we can throw up some of our poll questions. Ahmed, can you display those? Do we have, can we put up our poll question?
Yep. 1 second, I will.
I think, Mike, now's a good time to ask who's out there. What?
Yeah, that's, I wanted to see, maybe I just don't know how to see the poll questions, I guess.
I think it may be a little early. Ahmad is getting them ready, but there is a question from Dr. Alsari.
Yeah, let's go to some of our questions. Here's a Q&A question. Yeah, good question from Dr. Asari here. Shouldn't we be cautious? Would we be going down the same path that led us to use heparin and then activated protein C in sepsis? You know, is there a danger of feeding the fire here, Rachel? I mean, there's a lot of confusion. Is this DIC or not DIC? Are we feeding the fire? I mean, what's the current thinking on that?
Yeah, that's a really good question. We were very concerned about DIC at the very beginning, and we thought, is this DIC? Is everybody in DIC? But the actual number of patients in DIC is very, very low. We know that the patients that are in DIC do very poorly. There was one study which showed the death mortality rate was as high as 70, 71%. But the majority of patients are not. And it's very different than DIC. It's very different than people who are getting kind of catastrophic APLS. It's kind of its own combination of these coagulation problems and coagulopathy. And that's what makes it very challenging. And I think the heparin question is interesting. There was a theory that maybe there's antithrombin 3 deficiency with these patients, and maybe heparin's not working. That really hasn't panned out. I think there's been some studies of people looking at direct thrombin inhibitors, especially in people clotting off like CVVH machines and things like that. I think we still don't know the answer to that. In our own institution, we found everybody was clotting off their A lines, and they were lasting a very short amount of time, 2 or 4 days. We implemented a heparin protocol where people had heparin, low dose heparin through a pressure bag, and we got our lines to last much longer, up to about 14 days. So I think there's little issues that come up, and we're still learning from it. But I think that's a really good question. But I definitely think that we have learned that DIC is not a major significant complication happening to the majority of people. That's actually a minority.
And Rachel, another question that came through is, what do we know about Coumadin and NOACs? You know, some people will be on those just for AFib or other reasons. What do we know about the use of the oral anticoagulants in this setting?
Yeah, so that's a really good question. In our own hospital, when patients come in and they're already on an anticoagulant for another reason, either AFib or they've had a history of VTE, we actually moved them over to low molecular heparin. And the reason we did that is we have a number of clinical trials looking at various COVID treatments, and those were interacting with the direct oral anticoagulants. So it wasn't because we didn't think the direct oral anticoagulants were going to work or not work. We did not want to limit people's ability to get on a clinical trial. And as you probably know, people with COVID, they're fine until they're not, and they crash fast. And so we didn't want to then say, okay, let's hold it. And then once it's out of their system, then they can go on the clinical trial. So that's what we have been doing. One of the studies coming out of the NIH is going to be looking at direct oral anticoagulants. I think that's a question we don't have right now. But I think that's certainly something that, you know, there's no reason to think that they wouldn't do well as well.
Thanks, Rachel. Well, people are voting. Please do vote so we can see what specialty you practice. So far in the polling, it looks like we have about 23% of our participants are cardiologists, 19% are pulmonary critical care, 42% are other than interventional radiology, hemonc, hospital, general medicine, emergency medicine. So a lot of other out there. We hope all the others enjoy us this evening. Let's look at our second question. So our second question is this. Let's go to the, let me share the results of this one. Okay, so this is the results of what specialty you are. The next question we want to ask is, who cares for patients in your facility? So for COVID patients. So could we bring that second question up, Ahmed? The second question that says,
Sure.
What specialty cares for the ICU patient and COVID patient on the wards?
No problem.
It'll be the same kind of answers. The question changed, but the answers are the same. But let's
Well, Mike, that's an interesting question, because in our hospital, when COVID happened, a bunch of us got deployed to the COVID floor. So I'm certainly not an ID expert, and we were put on surge teams. So this will be an interesting question. I don't know.
Although this is really not specifically about COVID. I think this is really about pulmonary embolism in general.
Yes.
And it may have changed a little with COVID. It's a great question, but I think we should ask the question first, you know, who at your hospital primarily cares for patients with PE, submassive PE in general, not necessarily only COVID.
Yeah, great idea, Kenny. So yeah, vote here and let us know who's caring for PE in your hospital.
And forgive us if we left out somebody's specialty. I was noticing that 27% of people are other specialty, and there are others, I'm sure.
We only have so many, you know, so many things here, but Kenny, it does emphasize the fact that PE care is really a multidisciplinary thing, right? I mean, we don't have enough choices listed here, right?
Yeah, I think that's right. Well, that's the point of PERT, is multidisciplinary teams coming together to come to consensus as to the best treatment modality for a given patient.
So in our current polling, let me show the results. Let me share the results. Right now, it looks like pulmonary critical care provides a lot of the PE management, followed by cardiology and general medicine. But I think, Kenny, we'll get back to you in a moment to talk about PERT teams in general and their value. But I think this does show that a lot of different people care for these patients. I mean, can we go to our third question, which is, how are people managing VTE in the setting of COVID? So let's look at our third question now to see what our audience is doing. So if you could go to, here we are, yes. So this question focuses on the management of the ICU patient with severe COVID and an elevated D-dimer. So our highest risk patient, how are all of you managing that? Are you giving prophylactic anticoagulation? Are you giving systemic IV anticoagulation? Are you giving an oral anticoagulant? Or some of you just don't know? And well, or some of you are just managing it as we all do, which is to balance the risk of thrombosis and bleeding. So,
Mike, if I could comment on this while we're, asking the audience to poll. Rachel mentioned that there's several prospective randomized trials going on. Valentine Fuster at my institution here in New York has initiated a randomized trial for moderately ill patients, randomizing prophylactic enoxaparin to full dose enoxaparin to full dose apixaban. A 3-arm prospective randomized trial. It's a Freedom COVID trial. And then we have another randomized trial, which takes critically ill ICU patients in respiratory failure with an elevated D-dimer and randomizes them to half-dose tenecteplase versus placebo, because there's obviously a lot of interest in fibrinolysis for these patients. So I just wanted to mention that as we're polling the audience, that we're clearly in the era of enrolling patients in prospective randomized studies, so that hopefully in 6 months, when we meet again to talk about this, we'll have some of the answers laid out in front of us. But clearly there's a lot of prospective work that needs to be done.
well, thanks for that update. Yeah, I'm very excited to hear what comes out of your studies at Mount Sinai. It's a great effort you guys have put together. What do you think of these choices here, Rachel? Most people giving prophylactic anticoagulant. Is that a choice you would agree with? Let me make sure I've shared the results. 59% giving prophylactic anticoagulation, 24% giving systemic IV anticoagulation, very few people giving oral anticoagulants. What do you think? Is this on target?
Yeah, I think, again, given the very weak level of evidence that we have, prophylactic anticoagulation is currently what is recommended in patients in the ICU with severe COVID. And I wouldn't use, like I said, an elevated D-dimer to drive moving that to therapeutic. And like Rob, we have the clinical trials. I would encourage people to do those clinical trials. And I think outside of a clinical trial, you need to take every patient individually and see, but just using a D-dimer to throw on or increase the systemic or anticoagulation to full dose, we just don't have that data yet, whether it's safe and effective.
So Rachel, what would trigger you to do so? Or Eric, I don't know what you're doing at the BI, but I'd be interested to hear, because I think the different hospitals in Boston are doing totally different things.
That's surprising.
Maybe you should answer that question. And then I'd love to hear from Rachel, what would trigger you to initiate systemic IV anticoagulation? Eric?
Yeah, great question. And just stepping back, it's interesting. The observational data have overall supported anticoagulation full dose, but there's a lot of flaws in those studies, and they've really been critiqued for issues like immortal time bias and treatment selection bias. That the healthier people are able to tolerate a full dose anticoagulant and have less side effects. So it's very nice when you have controversial data that it motivates a trial instead of motivates guideline changes before we have trial data. So I completely agree with the approach that we really use prophylactic anticoagulation until this question has been addressed formally and we make it a patient-by-patient decision. We've done very similar to the Mass General at Beth Israel. We primarily use prophylactic anticoagulants. We definitely continue people on systemic anticoagulants if they were on one prior to admission. We don't move everybody to low molecular weight heparin, but I think that's a very interesting approach. But I think that we've really made it a priority to enroll people in trials. So we are also actively enrolled in trials, and I think anybody who's caring heavily for COVID patients needs to make that a mission, because we've seen with the dexamethasone data recently and some of our other trials that it's really changing our treatment paradigms quickly.
Rachel, we have a good question here about nebulized anticoagulants. There's a few therapies, including, nebulized, believe it or not, hydroxychloroquine, a big focus on getting all these drugs directly to the lung. What do we know about anticoagulation by the nebulized route to get right into the lung?
I don't know. I haven't seen any of those trials. If they're up and running, that's great. I'm not familiar. That's not something we're doing in our hospital. I'm not sure if Rob or Eric, you guys are doing that, but we have not been doing that. I don't know the data behind that. But
I know of some other trials looking at different nebulized approaches to the
yes, there are. I just don't know about the anticoagulants. I haven't heard of that. But I did want to address Kenny's question as to when you would go up. And Eric, I would graciously disagree that the observational data does not support full dose. I think there's a lot of flaws in that data. I think there's definitely some that suggest that. But I think your question, Kenny, and this goes back to the importance of a PERT team, because I think what happens is when you have ICU patients that crash, right? They become hypotensive, or they become either more short of breath or tachycardic. It's hard to know, is this person worse because of their COVID, or is this person worse because they got a PE? And if you have the capacity to get a scan and they're well enough or not sick enough, you can actually get them to the scanner and do that. But if you can't, and one of the things I think that's great about the PERT guidance document that's just came out in CHEST a few weeks ago, is that it kind of walks you through what you can do. And I think if you've got an X-ray that shows clearly worsening COVID and the person's not hypotensive or tachycardic, you can probably be comfortable saying that's probably the COVID. But if you've got somebody that's, hypotensive, more tachycardic, requiring more oxygen, and the X-ray is not showing that, then I think the concern is PE. And in those situations, if we're concerned enough through our PERT team, having a discussion, we will put people on full dose with that if we suspect that.
Great. Okay, that's a great lead-in for you. Talk to us about PERT more broadly. We focused a lot on the COVID patient, but I have to say an unintended consequence, perhaps, of this COVID epidemic is people have learned a lot about thrombosis and PE and the importance of all this. So it's a little bit of impetus for PERT. Talk to us about the evolution of PERT over 6 years, where we are now, where you see the PERT effort going.
Thanks, Michael. I appreciate the question. I think PERT has become a really great thing. It was an organic grassroots kind of thing that started. We started our team at Mass General, where we recognized that we really don't know, just like this webinar, we don't know what the best treatment is for patients with PE. We don't know when to treat them. We don't even know how best to diagnose it and how to recognize it. It's just a huge evidence gap in medicine when it comes to PE. When you compare this to acute MI or stroke or cancer, Rachel, or many of the other areas that we know so much about, there's been very little study in the area of pulmonary embolism. And PERT was really generated or created to not to fill the data evidence gap. It was originally just created because we needed to develop consensus amongst the different specialties who are taking care of this disease, which is a fatal disease in many cases, to come up with the best solution. So that was the genesis of PERT. But since then, and you're going to hear about this from Rob and from Eric, I think we've recognized that not only is it a vehicle for determining the best clinical treatment for a patient, but it also is a perfect platform for developing the very needed evidence base that we have. We're hoping it's not going to happen right away, but I think over time, PERT will be the vehicle that will answer lots of these questions, not just about COVID, Rachel, but actually, interestingly, COVID came up and PERT teams were already in existence, and it was the perfect segue, perfect storm in a sense. So that's what I would say. I think it's a young organization. There's a lot of excitement within the organization, a lot of passion. We will welcome new members. There's no cost to join. The only requirement is that you have some kind of a team at your place, 2 or more specialties that are helping to decide what to do with patients with acute PE. I'll stop there. There's a lot of great questions coming in, and maybe Rob might want to say more about it, but because he's been involved since the beginning. Actually, Rachel's been involved since the very beginning at Mass General.
Yeah, so, talk to us about the PERT database, Rob. I mean, very, very exciting what's built there. How big is it? How much data are you collecting? How many patients? Talk to us a little bit about that.
Thanks, Mike. So we've partnered with BCRI. Thank you very much for all your help, Mike. And we've been live for just under 2 years now, and by incredible support from so many physicians that are actively involved with taking care of patients with PE across the country, we've enrolled over 3,000 patients so far, and we're probably going to have a press release that gives an exact number early next week. But it's really a testament to how much interest there is and how much of an opportunity there is. We're going to look at the data so far. 3,000 patients is obviously a very, very large data set. We're starting to rival, I think, probably the most recent seminal data set for acute PE, which was ICAPER, which was published decades ago. And we really want to look at that and give a contemporary glimpse of what practice is for the last several years. There's a tremendous opportunity to learn lessons, share these lessons learned with the rest of the country and with the rest of the world, and then hopefully pivot to do a lot of prospective research and really try and identify where the next hypotheses need to be generated. And I, for one, am extremely optimistic. It's really great to have Eric Secemsky on this town hall, because Eric has been just an incredible collaborator to look at the database at where we are right now and really try and pivot of what signals and what directions we're seeing in terms of the patients we've been able to collect, what patterns we're seeing in terms of their outcomes, and how do we take that as a foundation, pivot and modify it moving forward into the next version, so that we can really start to answer some of the critical questions that we're talking about on this town hall tonight.
Well, it's great that it's functioning so well. I think all of our hopes is someday we can work with the FDA to make it regulatory ready, where we can use this as the backbone to randomize patients across the country to test out new drugs and devices in the management of PE. Eric, talk to us a little bit about the database, what you're learning, what you hope to ask and hope to learn from the database.
Thanks, Michael, and thanks, Rob. Also, Rob, it's been fantastic working with you on it. I think the most amazing part of this is that we have a database from high volume, high level centers with PERT teams in place. And every time we look at the database, we see variation in care across these centers. And again, this isn't just people taking care of PE. These are PERT Consortium centers, and we all vary in how we practice. And so, that has been the biggest learning point for me, is that we are still moving towards understanding a consensus, a standardized pathway for treating various risks of PE, and putting the picture together. And again, we get more tools every day now. We've really changed our toolbox for how we treat submassive high risk particular PE, that we need these data. So, I think the effort is fantastic and ongoing. This started with Rachel and Ken and Chris Cabral at MGH, and we had published, even I had published early on in fellowship some data there, and now we have the center with Rob behind it with more than 30 plus different PERT Consortium partners contributing data daily. So we are really poised to answer some seminal questions that we've been talking about for years, and again, what we talk about in the middle of the night on a PERT Consortium call. And I think we're excited. I know Rob and I are looking forward to showing some of that data at the PERT Consortium meeting coming up. And there's really a pathway forward here that's clear. And I also want to just thank everyone in the PERT Consortium who has been contributing their patient level data. I mean, that it's such a feat. It's a lot of work. And I think it's all going to the greater good of how we care for these patients.
Absolutely. There are a few data gaps, a little bit of missing data that we've identified, Eric. If you had a request to sites, what would it be to help fill in those gaps?
Yeah, absolutely. I mean, I think that's always a plague of analyzing registry data is missing data. So, we will, continue to really reemphasize the point that we appreciate everyone's effort, and we know it's a lot of work, but as complete as the data we get, the better the outcome will be. And so we've worked through that. Honestly, as we've worked through it, we've realized centers have done a phenomenal job. And there's always room to improve, but we're really thrilled. We're going to kind of, again, update everyone more formally at the consortium meeting. But, again, we have a fantastic database to work with, and we have a lot of big plans for this and fantastic partners across academia and industry that is going to help make this pretty much, the center of all PE care.
I'd like to thank Clara Fitzgerald, who's working with us, the statistician's doing a great job helping move all this along.
I'd like to thank her too. Yeah.
I'd like to thank Clara also.
Yeah,
she
she's our
is
best friend right now.
invaluable, and we cannot thank her enough. She's absolutely amazing.
So Kenny, what do we have to look forward to at the annual PERT meeting? What's going to be hot?
Gee, Rob should speak to that because he's one of the course directors, and I
Well,
really am going to deflect to Rob. Go for it,
what's
Rob.
gonna be hot?
Sure. So as Eric mentioned, we're hoping to give some very, very intriguing first glimpse of what the first 3,000 patients in the database are showing us. It's in many cases very humbling because of the diversity of the care that we're seeing. In many cases, it's very intriguing. We're seeing patterns that, honestly, if you had asked me 3 years ago, I never would have imagined that we would be seeing. It really does create tremendous open opportunities for how we can collectively move forward. We're also hopefully going to make some very special announcements regarding research initiatives, to be very honest with you. And, more to come on that, obviously, next week during the annual meeting. But I think your points about pivoting the database to try and make it a more comprehensive, prospective tool to record outcomes and possibly even randomize people. This is where the PERT Consortium is absolutely committed to going. And again, we're very, very optimistic. We're hopefully going to make some announcements about that next week.
Great. And again, go to pertconsortium.org to register now. We have a few more questions coming in. We have Jonathan Paul asking, what are people's thoughts on antiplatelets? Obviously, it's not just a venous disease. There's also arterial thrombosis. What do we know about antiplatelet therapy in the COVID setting? Maybe we'll start with you, Rachel.
So I think that's a really good question when we talked about the pathophysiology. If you think about kind of all those areas of what's being activated, and then thinking about where to target those areas, this is another area that I think is interesting and should be explored. At this point, we don't, again, have randomized controlled trials where people are on aspirin or not aspirin, but I think it's an area that is ripe for exploration. I would piggyback just what Rob said about, the TPA that they're looking. There's also actually 4 trials looking at eculizumab for the complement activation. So I just think there's all these different pathways. And I don't know if it's, you do one or you do a combination of them, but that question is very good. And I think that's something that people are interested in exploring.
Anyone else have any thoughts on antiplatelets? Let me ask a provocative question. Should he be on anticoagulation prophylaxis? What do people think?
Nothing more provocative than Trump.
Oh, I thought I'd get the juices flowing there. So, Kenny, what do you think? If you were the physician in chief, would you anticoagulate him?
It's a loaded question.
It's a really loaded question. Without being political, I think, I want to redirect a little bit and say, what about patients who, if there's no documented PE, then there's no evidence. I mean, this is where we need to develop evidence. This title of this town hall, evidence development. Where are the data gaps?
Yeah.
I think that if you believe that patients who have COVID are hypercoagulable for a certain period of time, then you might say it's not a bad idea to give maybe at least low dose prophylactic. And I'm not sure if Rachel can answer this, whether a DOAC is good enough, or does it need to be Coumadin, or does it need to be injectable like Lovenox or Pixabay, whatever, Arixtra or something like that. So I don't know the answer. I think if it was me, I'd probably be on a low dose of a DOAC, just in the absence of evidence. And I may be totally off base on that one, but I think I would probably put myself on a low dose of a DOAC for a couple of months.
I would put myself on Betrixaban. What would you do, Rob?
So I think that we're speculating because we don't really know what happened to the president when he was admitted. I think if he had an elevated D dimer, if he was hypoxic because he had a pulmonary embolism, without question, I would recommend him being on, at minimum, prophylactic dose enoxaparin, probably, well into past the election. In the absence of that, if he had a normal D dimer and didn't have a documented PE, I don't think we have the evidence base. I'm going to agree with Kenny about that. But we're just sort of speculating at this point. We don't really know what happened when he was admitted, unfortunately.
Eric, what would you do?
I would probably defer on prophylactic anticoagulant. I would consider taking like a full dose aspirin every day while I was recovering, or some sort of antiplatelet therapy. I think we know there's some data for aspirin and prophylaxis, and I would probably consider that over a low dose anticoagulant. But I'll pass on what I would do with Trump.
We've got 4 people. We've got at least 4 answers so far. So Rachel, what would you do?
So I would say, again, this is a data-free zone, a data gap, and there will be some trials looking at this and who would benefit from post-discharge anticoagulation after COVID. We do not have the answer. Like I said, there has been a few studies looking at the rate of clot after that, and it's been very low. So I think what I would do is, if I was going to put somebody on discharge, if I was going to discharge them, and we know everybody's getting prophylactic anticoagulation while in the hospital, if I was going to put that person and continue them on prophylactic anticoagulation on discharge, regardless of whether they had COVID. So let's say it's someone who's still immobile and going to rehab and really not getting out of bed, I'm going to continue that prophylactic. I would do that. I think in the absence of data that supports using these drugs just on discharge because they had an elevated D dimer, I think it does bring up the concerns about bleeding and other things, and then we might be over treating people. But this is one of these areas that we just need more data. And who knows what happened with the president? He might have had a clot. Who knows? We don't know anything about that. So it's hard to answer what I would do for him because it's just a data not known zone. That's what I would say. But I think for the majority of patients.
Do we know anything about Decadron and thrombosis? I mean, have we identified any interaction there? I'm not aware of any.
No, I think, again, when you take these patients in the ICU who are on Decadron or vasopressor, all the stuff, they're sick, they're inflamed, they're all that, what's playing into what, it's hard to know. There's a lot of confounders, but at this point, I don't think we have evidence that's suggesting that is causing blood clots in these people.
We do have a question about inotropes and the low flow state with inotropes. Any heightened risk of thrombosis when you're on inotropes? Rachel, you're on mute.
Sorry, I didn't know if somebody else wanted to answer that. Again, not that I have read about. Again, I think these people we don't know all the kind of combinations of what's causing all of their issues. So it's hard to tease that out, but not that I am familiar with. I don't know about Eric or Rob, if you've seen that, but.
No, we are not witnessing that at our institution.
Yeah.
Good question here about protein S levels in severe COVID-19. Does COVID drive down protein S? Anyone want to answer? Anyone know?
That's a Rachel question. You know that.
Yeah. So we did look at when patients were in the ICU, we were looking at various hypercoagulable markers in patients. And one of the ones we were really interested in was antithrombin 3. And we didn't really see a pattern with that. And clotting per se, or severity. And I think it's the same with protein S. I mean, I think we didn't see any significant pattern with that. I think when people have blood clots, we know that their protein C and protein S can go down in an acute clot. And so in that setting, it's hard to sometimes tease that out, but we haven't found any significant patterns in our COVID patients with that.
Michael, can I ask I just have a quick question. I was thinking about this for Rob and Ken. Did you guys use any catheter-directed lysis or mechanical embolectomy during the kind of the heat of the COVID movement? We had a few PERT calls. We didn't have a tremendous amount of PERT calls, and I think some of it was also there were a lot of competing risks where there might have been situations where there were, irreversible positions patients were in that we didn't have many options. But we didn't take really in the heat of it anybody to the lab for a procedure. Again, we were also learning a little bit about how to protect ourselves. We lysed a few people on the floor. But I'd love to hear what everybody else was doing on the mechanical side.
Before we hear from them, could I ask, Ahmed, could you put up question number 4, which is what proportion of patients at your hospital are undergoing invasive management? Great. So while we're listening to Kenny and Rob, let's have people vote on that.
Can we actually have this not be about COVID though? I mean, let's just ask without COVID.
Oh, sure, without COVID.
Yeah.
In the non-COVID environment, what proportion, or right now, what percentage of high-risk submassive PE undergo invasive treatment?
So we're confining this to high-risk submassive PE, and what proportion undergo invasive treatment.
Yeah.
The votes continue to go up. What are you seeing at the general, Kenny?
I think that COVID probably did cast a pall over this. We definitely were using some half-dose lytic and had a higher threshold. Our threshold's pretty high for intervention in the first place. I think one of the fallacies is that PERT leads to more procedures, and I actually think that at our institution it probably has been the opposite. It's led to a sort of conservative watch and wait and see approach often, where we'll evaluate a patient over a number of hours. And that's a good approach. I mean, I don't think that was done before. People made instantaneous decisions and then just went with it. Now we are making decisions to do that in some instances, but we're also the variation that you described, Rob, earlier, or actually I think Eric, you described this huge variation in treatment. We've narrowed that variation. It's still some variation, but it's not nearly as broad as it was before, and I think that's one of the contributions that PERT will do, I think. So I don't know if that answered the question, Mike.
Yeah,
but
Rob, at Sinai, real quick, let's just hear from Rob. You're on mute, Rob.
Sorry. I'm going to echo some of the things that Kenny said. We defaulted as a reflex to systemic lysis. And that was, I think, because of two things. One was that we were concerned about what the perceived risk was to the staff by putting the patient into the cath lab. We didn't know. Secondly, we were concerned about what the potential risk was by mobilizing a patient and wheeling them from an ICU to a cath lab, or from an ICU to a CT scanner if they were to crash while in the ICU. And so our reflex, especially for the hospitalized critical care patient, was if they were to crash in the setting of an elevated D-dimer, they would get systemic lysis. There were exceptions, and I think as a reflex, we were using mechanical aspiration as a default instead of CDT, because it was a sort of single stop setting therapy instead of moving a patient back and forth and sort of watchful waiting. But now we know that PPE does protect the staff. The risk is much less than what we thought it was back in March. I'm not trying to trivialize it, but we did a number of procedures back in March and April in New York on COVID positive patients where they were documented to be positive. and virtually nobody on the staff converted at all. So we really feel the PPE is safe. And as we're starting to see a small uptick in the cases in New York, we're having active conversations about when those calls start to happen for documented COVID positive patients, what's our strategy going to be? And honestly, we don't have consensus yet. We're going to probably tailor it to the individual patient, but we clearly see now, in distinction to March and April, that there will likely be a role for catheter-based therapy in the lab for these patients that are becoming more and more unstable while they're in the hospital.
I would agree with that. I just want to comment that I think, Rachel, you mentioned the paper that you were first author, I was last on, that was published about the PERT sort of approach to PE in the COVID era. And I think that addresses some of this. Is a section about what about intervention and how you manage it. And it does give some general guidelines, but I think again, consensus is what drives therapies here.
Yeah. I just want to make,
Okay.
sorry, just one more comment earlier for your Ken, you made a comment about people think that PERT increases the use of therapies. And one of the confounding comments there is that a lot of these therapies were originating and starting when PERT was coming about. So, there weren't alternatives. But one of the best metrics that we have that PERT is meaningfully making a difference in how we care for patients is IVC filters tend to be lower. Rates of IVC filter use in the PERT era are lower. And we published that. Dr. Ida Weinberg was a senior author on a MGH-based PE analysis back a couple years ago. And so I think that that does show that there is a quality metric here that we are achieving by standardizing care.
Yeah, and I would add, I think using PERT, during COVID is really important for all the reasons that were discussed. And just to add to what Eric said, there's actually a lot of literature now. I think when PERT first started, if you did a PubMed and put in PERT, there were maybe 16 articles. If you do it now, I think there's over 200 articles. But there's a lot of articles that are looking kind of before and after and showing actually articles that have shown that not only does it decrease length of stay, faster getting somebody therapeutically anticoagulated, but also decrease mortality. Now, it's not a randomized controlled trial. You're not going to randomize, half people get the PERT and half don't. That'd be hard to do. But I think there's a lot of really, really good data out there now that is showing the benefits of this. And I would emphasize again what Rob said. I think this is the ideal time when you're dealing, especially with these COVID patients, where you may be limited in getting people to the cath lab. You can't expose all those people. Maybe you only have one person that's doing cath, and so if you look at the algorithm is in those low resource settings, we do recommend in somebody with a massive PE that you go ahead and give, if there's no contraindication, doing the lysis, because I think you're going to be stuck. Now, if you're somebody and you got all the resources, then yeah, go ahead and go through that. But I think that's what makes, that's why a PERT team in this setting, I think, can be invaluable and really, really helpful.
Rachel, that's actually a good segue to our last question. Before we go there, though, just want to point out the central tendency here was about 10 to 30% of hospitals or about 10 to 30% of patients are utilizing invasive services. The second choice was under 10% and a third of patients. So 48%, about half the centers are sending 10 to 30% of their patients for an invasive procedure. About a third are using it under 10% of the time. Can we go to our last question, which kind of ties into what Rachel was saying in terms of quality assurance and having a PERT program? Do you have a current mechanism for assessing the quality of your hospital's PE management at your center? So let's see what the centers say here.
And as people are doing that, I just also want to point out early on when we looked at the Mass General data with Chris Cabral, we actually did show a before and after PERT, that after PERT there were more advanced therapies, but despite that, even with that, there was no difference in bleeding, which I think is really important to point out.
Actually, one of the most important findings early on was that at 24 hours, less than 50% of patients were actually therapeutically properly anticoagulated. And that is probably a universal problem because of the way we dose anticoagulation in the current era or before. I think now Nowadays, people are moving more towards injectable, not parenteral, and that's probably better. But that was a real eye-opening thing for us. And, of course, during that time, those patients are highly at risk for propagation of thrombus. So it's small things like that actually make a huge difference. And the PERT database, that came out of the PERT database, Rob, no?
Yeah, so if I may, that one of the great benefits of participating in the PERT database is that every member organization that contributes cases to the PERT database gets quarterly a dashboard sent to all of their staff, all of their members, that records all of their cumulative cases, what their diagnostic rates are, what their acute in-hospital outcomes are, and what their rates of follow-up are for all of their patients that are enrolled. Not only is that dashboard a mirror of the performance of the individual institution, but it allows the institution to see how they compare to the collective of the rest of the country. And so if they find that, for example, they're putting filters in on 50% of the cases, just as an example, and the rest of the country is only doing it on 15% of the cases, they could probably think of, well, maybe we're putting in too many filters. Or if their bleeding complication is, unfortunately, God forbid, 15% of all cases have a major bleed while in the building, and the national average is far less than 5%, they can focus on that, tackle it, and put in the metrics to try and lower that adverse event rate down. So we've attempted to create the foundation where an institution can look at their own performance, compare themselves to the rest of the country, and create a mechanism by which they can measure quality at their own institution.
So, Rob, we have about over 50% of people saying they don't have a QA program at their hospital. In the poll, is PERT a way that they could use PERT to become their QA program, obviously?
I would humbly say, please join the organization, contribute patients to the database. We are here to help you. BCRI is here to help you. We have been extremely successful. The feedback that we're getting from our organizations that are partnering with us on the database has been spectacular. They find it so valuable that they can see how they're doing in real time, compare their performance to the rest of the country. We will welcome all new members and new participants with open arms. So yes, please join us. The more the merrier. We want to have a very open house so that we can really advocate for our patients and improve the outcomes that we're seeing.
You said participants. Are they participants or are they participants?
And
will they give
very good point. They're all participants. Thank you.
Perfect care. So, Kenny, let's go to you. We've got 1 minute left. What do you have to say to get people on board on PERT?
I just echo what Rob said. I just want to make sure to emphasize our annual meetings coming up next week. Tune in. Saturday afternoon, there's a special musical talent that you'll hear. I won't tell you anymore. The second thing is join the database and join PERT. Join the database. Just we're a welcoming organization. There is no cost. It's tedious to collect the data, but that's what it takes to ensure quality. At the end of the day, at some point in time, we're going to try to probably identify PE centers of excellence. And to be a PE center of excellence, you really need to have your own data, collect it, be able to look at it, and then benchmark it against others. But otherwise, I just want to thank you, Michael, for moderating this session. You've done more for this space than just about anybody in the clinical trials that you've run and the organization that you run. And partnering with you at BCRI has been a real pleasure, and we're looking forward to working together. So thank you for doing this.
Yeah, well, it's one of the things I'm most excited about spearheading with you and Rob and Eric and Rachel is really moving this database into a mode where we can use it to perform randomized trials. I think that's very, very exciting. And I know the FDA is very excited about it as well. I want to thank you, Kenny, Rob, Rachel, Eric, and our whole audience for such an engaging evening. Thanks for all your great questions. Thanks for all of you for acknowledging the gaps and answering with your expert opinions and acknowledging what we don't know, because we don't know a lot. And I look forward to your upcoming meeting, Kenny and everybody. Thanks, everybody. Have a great evening.
Thank you very much, everybody. Stay safe.